diphtheria case in your lifetime, but you should know about diphtheria, because if you encounter any case of diphtheria, so that immediate treatment can be started. Though we are studying the microbiology of diphtheria, but diphtheria is a clinical diagnosis because you have to start treatment immediately. We cannot wait for the microbiological confirmation. So diphtheria, what is the motto of reading? That even if you encounter a single case of diphtheria, you can suspect and start the treatment. So before we go to the diphtheria, I have intentionally included the streptococcal pharyngitis. That is the commonest. Let them get in. I have intentionally kept few slides of bacterial pharyngitis of streptococcus or beta hemolytic streptococcal, because that is the commonest differential diagnosis, and that case you will enter many times in your clinical career. But diphtheria you may or may not see in your clinical career a single case of diphtheria after the vaccination has started. So clinical case of diphtheria is very rare. So what are the learning objectives in this class? So that you can learn about diphtheria, you can differentiate between streptococcal pharyngitis and diphtheria, and the diagnostic procedure is almost the same. It is the most common upper respiratory infection you will encounter. Just what are the causes of pharyngitis? That may be bacterial pharyngitis, there may be viral, and among the bacterial pharyngitis, two most important bacteria are beta hemolytic or group A streptococcus and diphtheria. So streptococcus and corynebacterium diphtheria are the two most common organisms. Please don't talk. These are the rare causes of bacterial pharyngitis. Other hemolytic streptococci, group C and group G, Arcanobacterium, Fusobacterium, Mycoplasma and Neisseria. Now streptococcal meningitis is already covered in the last class. So I will just show you a picture of streptococcal pharyngitis and how it is. This is the streptococcal pharyngitis or tonsillopharyngitis. There is a white patch of tonsillar fossa, that is the streptococcal pharyngitis, that is the cause of localized tonsillitis, or it may cause diffuse pharyngitis. So you can see the enlarged tonsils covered with white fibrinous exudate. Now how we will diagnose? The differential diagnosis, as I have told, is diphtheria and viral pharyngitis. So the diagnostic method would be the same, whether it is a streptococcal pharyngitis or diphtheria. Same culture, and that will be gram-positive cocci in chains. Now we come to the today's topic, that is diphtheria. What is the causative agent of diphtheria? Corynebacterium diphtheriae. What is the meaning of corynebacterium? Can anybody, what is the meaning of corynebacterium? What is the meaning of corynebacterium? Means club-shaped bacilli. Corynebacterium means club-shaped bacilli, and this is one of the example of gram-positive bacilli. What are the other example of gram-positive bacilli? Can anyone tell the other names of gram-positive bacilli which will you encounter? This is one example of gram-positive bacilli, Corynebacterium diphtheriae, or Corynebacterium is the gram-positive bacilli. Other examples are Bacillus species, Clostridium. Bacillus or Clostridium are with spore, gram-positive bacilli with spore. Corynebacterium is non-sporing. Other gram-positive bacilli examples are Listeria and Actinomycetes. So these are few examples of gram-positive bacilli. Now Corynebacterium diphtheriae is highly infectious. Corynebacterium diphtheriae primarily infects the throat, tonsil and larynx. So that involves the respiratory tract. That is the main causes an exudative pharyngitis and membranous tonsillitis. Now what is the history? In 1826, Pierre Bretonneau give the diphtheros, meaning leather-like. Why he has given a leather-like? When we go towards the next pathogenesis or the disease process, there will be a pseudo-membrane. A leather-like membrane usually forms over the tonsillar fossa. That's why initially the history was first given the name diphtheros, meaning leather-like. First observed by Claves in 1883, first cultivated by Loeffler. So that's why diphtheria bacillus is also called Clave-Loeffler's bacillus. So why it is called a Clave-Loeffler's bacillus? First observed by Claves in 1883 and the first cultivated by Loeffler in 1884. Now gram-positive, it is a non-capsulated, non-motile bacillus. Diphtheria is non-capsulated, non-sporing, non-motile bacillus, club-shaped swelling of the both sides of the bacillus. That is diphtheria. This is the staining method of one of the staining method. I will come to the staining method later on. Now this is the difference. What is the arrangement? Whether you do gram stain, whether you do Albert stain is a specific stain for diphtheria. The arrangement is typical. What is the arrangement? Arrangement is called Chinese letter pattern arrangement. Chinese letter pattern or cuneiform arrangement is a typical arrangement. So when a sample is sent to you for a throat swab, if you cannot confirm from the staining that it is Corynebacterium diphtheria, but you have to inform the clinician, or the clinician will need to know whether you get a V or L-shaped Chinese letter pattern arrangement gram-positive bacilli, so that he or she can start treatment of diphtheria. So this arrangement is a typical V or L-shaped Chinese letter pattern. The second specific point of diphtheria is the metachromatic granule. Metachromatic granule present at ends of both poles of the bacilli. So what is the difference between the Corynebacterium diphtheria is a pathogenic organism? You will encounter other gram-positive bacilli that are common cells in the throat or other skin. Those are called diphtheroids. They are not Corynebacterium diphtheria but diphtheroid. What is the difference between the in the staining method of diphtheroid and diphtheria? These Corynebacterium diphtheroids are non-pathogenic, they are having a palisade type of arrangement, not the Chinese letter pattern arrangement. Diphtheroids, non-pathogenic, common cells, they produce in staining a palisade type of arrangement. Now the metachromatic granule, a short note can come. Metachromatic granule is one of the most important identification point of Corynebacterium diphtheria. When you do typical particular stain or specific stain for Corynebacterium, they consist of polymetaphosphates. So they also called polar bodies, wave earnest granule. They are composed of polymetaphosphates. They stain strongly gram-positive compared to remaining part of the bacilli. They are bluish purple metachromatic color when stained with specific stain. Loeffler's methylene blue is one of the stains where it was bluish purple metachromatic granule. Now you must remember which part, that is the metachromatic granule consists of polymetaphosphates. If you forget other part, at least remember it consists of polymetaphosphates. They are better stained with Albert stain. Remember the name. Whenever you are studying Corynebacterium, Albert stain is specific stain for diagnosing Corynebacterium. So remember the name of Albert stain. If you forget other stain, Neisser stain, Ponder stain can be used. But commonly what is used in the laboratory is Albert stain. Albert staining is the staining method used in staining Corynebacterium. And this bacilli looks like greenish and the dark purple like in the metachromatic granules and dark purple like. So this is The staining method, Loeffler's serum slope. What is Loeffler's serum slope? Loeffler's serum slope is a specific media. Whenever you get any suspected case of diphtheria, you must inoculate it in the Loeffler's serum slope. What is the why this media is used? There is a two importance of this media, Loeffler's serum slope, or in short LSS. The colony appear within 6 to 8 hours. That is the earliest, because turnaround time must be less. When you are diagnosing diphtheria, turnaround time must be less. So LSS is a specific media, that is an enriched media. So colony appears within 6 to 8 hours, and if you stain from that colony, the secondary stain, the metachromatic granules will be more prominent. So this is the two advantages of LSS. Loeffler's serum slope, the colony appears within 6 hours, and the metachromatic granules are more prominent when we inoculate in Loeffler's serum slope. So this is again some recapitulation. Causative agent of diphtheria, this is pleomorphic gram-positive, possess polymetaphosphate. Cornybacteria have been typed based on, this is biotyping, gravis, intermedius and mitis. It was now commonly not followed in all laboratory, but this is the biotyping of Cornybacterium diphtheria. It is divided into Cornybacterium diphtheria gravis, intermedius and mitis. And their pathogenicity is due to toxin, not due to bacteremia. This, remember, all the disease produced by the respiratory diphtheria causes due to the toxin in the diphtheria, not due to bacteria itself. So there is no bacteremia. When it is a pathogenesis, we will go to the pathogenesis of Cornybacterium diphtheria. It is mostly due to toxin only. No bacteremia is there. Now virulence factor. What are the virulence factors? One is toxin polypeptide chain composed of two fragments A and B. So whenever you get any toxin and you get an A and B part, A is always the active part and B is the binding part. So in which part it binds? Epithelial growth factor. Epithelial growth factor is the receptor where this toxin binds. Epithelial growth factor is the receptor where this toxin part B binds. Fragment A, what is the mechanism? It causes ADP ribosylation of elongation factor 2. Remember this pathogenesis, ADP ribosylation of elongation factor 2. What happens when elongation factor 2 leads to inhibition of elongation factor 2, and that leads to inhibition of translation of protein, and the protein synthesis is disturbed. So this is the mechanism of diphtheria toxin. It is ADP ribosylation of elongation factor 2, inhibition of elongation factor 2, inhibition of translation step of protein, and protein synthesis is inhibited. Next, toxin, fudge coded, beta cornifudge. Fudge coded means that is a cornifudge, a virus. Still it is in the Cornybacterium diphtheria bacilli. Till then it is toxigenic. If the cornifudge goes out of the bacillus, the Cornybacterium diphtheria become non-toxigenic. So this tox gene or the virulence factor is only expressed when it is infected with cornifudge, a fudge virus. So that is called fudge coated. Iron concentration 0.1 milligram per liter. Why iron is needed? It usually a gene regulator protein is there, that is DTXR. DTXR is capital. DTXR, that is by negative suppressor method, the iron using as negative suppressor of DTXR, and this toxin is expressed. So second part is this part. Even if you don't remember the DTXR, you just remember it is fudge coded. The bacteria must be infected with the bacteriophage to express the toxin. And the second part, iron is needed in a very small 0.1 milligram per liter for expression of the toxin. Now here another point, other species except other than Cornybacterium diphtheria, Cornybacterium ulcerans and Cornybacterium pseudotuberculosis, also produce the toxin. When you will go to the laboratory diagnosis, remember how will you differentiate between Corynebacterium diphtheria with Corynebacterium ulcerans and Corynebacterium pseudotuberculosis. A single test can be done to differentiate these three. What is that test? That is urease test. Urease test, Corynebacterium diphtheria is urease positive, negative, sorry. Corynebacterium diphtheria is urease negative, and Corynebacterium ulcerans and Corynebacterium pseudotuberculosis are urease positive. This is one of the MCQ. The type of infection caused by potentially toxigenic Corynebacterium diphtheria has changed over the decade. Why it is changed? Because the advent of vaccination and universal vaccination has led to the decrease in the respiratory diphtheria. But what we can get is some atypical disease, and mostly those atypical diseases are cutaneous diphtheria or other myocarditis, endocarditis, septic arthritis type. Severe and recurrent episodes of sore throat. These are the alternate symptoms of diphtheria. Toxoid is used for vaccination. What is the vaccine used in diphtheria? DPT. So DPT, what is the course schedule of DPT? When we give DPT? DPT, what it contains? D for, that is diphtheria toxoid and tetanus toxoid, and P for whether it is a toxoid or killed, which is pertussis. Pertussis is a killed pertussis. Now we are also using acellular pertussis as part of DPT. So diphtheria is a toxoid and tetanus toxoid, and pertussis is killed pertussis vaccine. That has converted to toxoid. Now how will you convert the toxin into toxoid? And toxin, for toxoid form of toxin where virulence is lost but immunogenicity or antigenicity is retained, so that it can use as a vaccine. Toxoid formation. So how you can convert the toxin into toxoid? That can be by using of low pH, use of formalin, that can lead to prolonged storage. These are the 3 points, but it's commonly produced by use of formalin. The diphtheria toxin is converted to toxoid by either using formalin, it can be in low pH or prolonged storage. Now what is the strain used in diphtheria toxoid? That is specific. This is another MCQ question. Park-William 8 strain. Park-William 8 strain is used for production of the vaccine or the toxoid. Loeffler limit of flocculation unit or LF unit. Can anybody tell what is the amount of Loeffler unit used in DPT vaccine? D, that is 25 LF unit is used in DPT vaccine. Now pathogenicity. What I told initially and again, the diphtheria or the respiratory diphtheria is due to toxemia only, but never a bacteremia. So bacilli are non-invasive, they secrete the toxin, spread via bloodstream to various organs. And toxin responsible for all types of manifestation, local and systemic confirmation. So this is the main point of pathogenesis. It is mainly due to toxemia, not due to bacteremia. So if you use antibiotic only, it will not work. When antibiotic can work, when you go to the treatment, antibiotic only work within 6 hours when the toxin has not been released. So the antitoxin has to be given in the treatment of diphtheria. That is the main point why we are learning the pathogenicity. It is due to the toxemia. Respiratory diphtheria is the most common. What is the tonsil and pharynx? Phaseal diphtheria. Phaseal means tonsillar diphtheria. It can also lead to the laryngeal diphtheria. What will be the symptom of laryngeal diphtheria? Tonsillar diphtheria may or may not cause breathing distress, but if it involves larynx, there will be stridor. that is a stridor obstructive airway disease. The stridor will appear, that stridor will prove that the larynx has been involved. So respiratory diphtheria, three common parts, tonsil and pharynx, and larynx can also be involved. If the larynx is involved, there will be inspiratory stridor, and that can be, the sound can be heard even if you go near to the patient. That is, stridor occurs due to the involvement of the larynx. So incubation period is 2 to 7 days, usually average 3 to 4 days. Fascial diphtheria. You see the picture, there is the greyish white membrane over the tonsillar fossa. I will show a better picture. An inflammatory response leads to necrosis of the epithelium. That necrosis epithelium and exudate and mucosal ulcer lined by tough, leathery, greyish white pseudomembrane. So how you can say this is a pseudomembrane, not a true membrane? How can you differentiate clinically it is a pseudomembrane or true membrane? So if you try to remove the pseudomembrane, as it is not a proper membrane, it will not come out. It will come difficulty to come out, and there will be bleeding spot. When you try to remove the pseudomembrane, that's why it is called not a true membrane, it is a pseudomembrane. So that is pseudomembrane covering the tonsils. Remember the term pseudomembrane and how it forms due to the necrosis of the epithelium, necrosis of the tissue, the exudate formation and mucosal ulcer. That is another picture. You can see by the light, there is a greyish white membrane inside. This is a more clear picture. Strongly adherent. The pseudomembrane is usually typically strongly adherent to the tonsillar fossa. If you try to remove the pseudomembrane, you can see the bleeding spot below underneath it. That is called pseudomembrane. Extension of pseudomembrane, that may lead to, there is another term, bull neck appearance. That is a tonsillar swelling leading to involvement of cervical lymph node and formation of bull neck. Neck edema, involvement of cervical lymph node, and what other features? There will be foul breath, thick speech and stridor. That stridor is due to the laryngeal involvement. So this you remember the bull neck appearance, but it is very late. If you get the bull neck appearance, the patient will be in a dire state. Now this is a classification. Diphtheria classified on clinical severity. There may be malignant or hypertoxic diphtheria. There may be septic diphtheria and hemorrhagic diphtheria. So malignant means severe toxemia, marked adenitis, that is bull neck, death due to circulatory failure. Septic leads to ulceration, cellulitis and even gangrene around the pseudomembrane. Hemorrhagic, bleeding from the edges of the membrane. There may be epistaxis, there may be conjunctival hemorrhage, purpura and general bleeding tendency. So these are clinical classification of diphtheria. Common complication, there may be asphyxia, there may be myocarditis, there may be acute circulatory failure, post-diphtheritic paralysis, polyneuritis can occur involving the cranial nerve, local necrotic changes, non-toxigenic strain. Here are two MCQ I have not intentionally given in what is the commonest muscle, first muscle involved in cornybacterium diphtheria. That is diphtheria, what is the ninth cranial nerve is involved? The muscle which is first involved in diphtheria is palatopharyngeus. Palatopharyngeus is the first muscle that is involved in diphtheria. Now what is the first muscle that is involved in tetanus? Tetanus you have not already studied, but tetanus, remember, masseter, because the first symptom is lockjaw in tetanus. Masseter is the first muscle that is involved in tetanus. So what can occur? There may be other organ involvement, there may be myocarditis, there may be neurological complication, and among the neurological complication it can involve the cranial nerve and peripheral nerve as well. Neurologic manifestation are toxin-mediated, non-inflammatory, demyelinating disorder. So what type of neurological complication? It is basically a demyelinating disorder, cranial nerve involvement, peripheral neuropathy, Myocarditis typically associated with, what are the features of the myocarditis? There may be arrhythmia or there may be dilated cardiomyopathy. This is the whole pathogenesis in a single slide. For recapitulation, what is the main pathogenesis part? Is the penetration of bacilli, formation of bacilli, no bacteremia, penetration of bacilli, local fibrinous inflammation, toxemia and penetration of the toxin into the tissue, blocking of ribosome and cell necrosis, and that lead to involvement of cardiac cells. It involves myelin layer of the peripheral nerve and tubular epithelium of the kidney. This is the pathogenesis in a single slide. How the pathogenesis start: Corynebacterium diphtheria, diphtheria toxin having A and B, the B component of the, that is the binding part that attaches with epithelial growth factor, then it intrudes inside the cell, and the A component or the active part that lead to ADP ribosylation and inhibition of elongation factor 2, that leads to inhibition of protein synthesis, and that leads to cell death. This is a single slide recapitulating the whole pathogenesis. Cutaneous diphtheria. In which patient cutaneous diphtheria? Still we were studying the respiratory diphtheria, and respiratory diphtheria is due to toxemia, only due to toxin, but the cutaneous diphtheria is not due to toxin, it is due to bacteremia. Remember, the cutaneous diphtheria even you can get in a vaccinated patient. So cutaneous diphtheria you can get in a vaccinated patient, because what we are giving in vaccine, that is an antitoxin. So bacteremia can occur, and that can lead to cutaneous diphtheria. Multiple punched out ulcers may be seen and not caused by non-toxigenic strain. Now this has increasing incidence, especially in vaccinated children. So even in vaccinated children, cutaneous diphtheria can occur because it is not due to toxin, it is due to bacteremia. This is one, a 5-year-old boy, fully vaccinated, was brought to the emergency and with pruritic lesion and punched out ulcer with a membranous exudate over the ulcer, and when you do a gram stain, you see this gram positive bacilli. So this is one of the example of cutaneous diphtheria. On presentation, she was afebrile. The lesion had appeared 3 weeks. Another example of cutaneous diphtheria, multiple punched out lesion or ulcerative lesion with fibrinous exudate above the ulcers. Now laboratory diagnosis. This is very important part, the laboratory diagnosis. How we'll know, but first I have already told the diphtheria is a clinical diagnosis. When you are clinician, don't wait for the laboratory diagnosis to confirm the Corynebacterium diphtheria. Start. If you are suspecting, you get pseudomembrane or you get stridor, start the treatment with antitoxin. Because time is a great factor here, so laboratory will confirm the diagnosis later. Don't wait for the laboratory diagnosis to start treatment in case of diphtheria. So what are the things? Specimen, what specimen will you send for Corynebacterium? Whether it is a bacterial, other bacterial pharyngitis, the specimen is same. What are the specimens that can be taken for laboratory diagnosis? Throat swab or swab from the tonsillar fossa or the part of bead of membrane can be taken for sample. Now at least 2 swab. Always send at least 2 swab because staining is very important. So 1 swab for staining, either drum stain or Albert stain, and another swab for culture. So always send 2 swabs when you suspecting a case of pharyngitis or streptococcal pharyngitis or diphtheria. Always remember, try to send at least 2 swabs so that contamination does not occur. Then gram stain, club-shaped gram-positive bacilli with Chinese letter arrangement, and Albert stain, green bacilli with bluish-black metachromatic granule. This is the initially primary staining. In all bacterial infection, what has to be done? One is for the primary staining, then the culture, followed by secondary staining, and then biochemical identification. It is all bacteriological diagnosis. This dictum will be followed. The primary smear to be done either by gram stain, but when you are suspecting diphtheria, always mention in the investigation form for Albert stain also. Because laboratory people may miss if you don't mention the diagnosis of Corynebacterium diphtheria. So when you are sending swabs suspecting diphtheria, always mention for Albert stain. Now this is the composition of Albert stain. Albert stain is composed of two, Albert A and Albert B. What are the main component of Albert stain? So main component are toluidine blue, malachite green and glacial acetic acid, and Albert B is iodine and potassium iodide. So remember, this is the composition of Albert stain. Albert stain part A contains the toluidine blue, malachite green and glacial acetic acid, and the next part Albert B consists of iodine and potassium iodide. Now culture media. What are the culture media? Already I have mentioned Loeffler's serum slope. Loeffler's serum slope is not a specific media. It is an enriched media where you can get the colony within 6 to 8 hours. So 6 to 8 hours is other media which can be used, blood agar, chocolate agar, there will grow, colony will grow. But Loeffler's, when you are suspecting diphtheria, always try to inoculate in Loeffler's serum slope. And the second part, second specific media. What is the specific media? When you are asked what is the specific media of diphtheria, that is potassium telluride agar. Potassium telluride agar, and that produce black colony. Potassium telluride agar is a selective media. One is Loeffler's serum soap and another is potassium telluride agar. Remember these two media for diphtheria. One is Loeffler's serum soap for quick getting the colony very quickly within 6 to 8 hours, and potassium telluride agar, that is specific for. Other commensal will not grow. This is the specific media for Corynebacterium diphtheria. Biochemical test as sugar fermentation, his serum sugar media. Sugar fermentation can be done by his serum sugar media and automated identification system such as Vitek. So what is the automated identification? Malditop is not available in all over West Bengal except in the CNCI Rajarhat campus. Malditop is not available. Have you heard the name Malditop before? Malditop detects the organism by the proteomics, not by genomics. By the protein, it identifies. Malditop is a very specialized equipment. It's available in West Bengal only in CNCI Rajarhat campus. No other medical college or no other hospital is having Malditop at present. So don't mention Malditop. It is mentioned in the, but you can mention the Vitek. Vitek is automated bacterial identification system. Next is you have diagnosed, it is, can you confirmly tell from those biochemical tests it is Corynebacterium diphtheria? No, you cannot tell that it is Corynebacterium diphtheria until and unless you demonstrate it produces toxin. So toxin demonstration is the most important part to stamp it as Corynebacterium diphtheria. What you can say from the stain, that you are suspected of Corynebacterium diphtheria, but confirmation toxin demonstration is must. So how you can demonstrate the toxin? That is the in vivo, in vitro. In vivo is in the living animal. What is the animal that is used for toxigenesis test previously? The guinea pig was used for subcutaneous and intracutaneous for the diphtheria toxins. Now animal experiment is mostly not done, but you just for theoretically you remember the guinea pig inoculation is the in vivo test for toxin demonstration. Next, in vitro test, Alex gel precipitation test. Remember this term, this is Alex gel precipitation test. What type of test is this? This is a gel electrophoresis test. Elex gel precipitation test is a gel electrophoresis test. Have you read the serological test? Outer Lani, this is a outer Lani, double diffusion, double dimension test, Elex gel precipitation test. That is, you just remember this is, if you don't remember those hard terms, it is a gel electrophoresis test, that is Elex gel precipitation test. What are the other methods of detection of gene? By PCR, polymerase chain reaction, you can detect the tox gene. Tox gene can be detected by PCR. The toxin can be detected by ELISA or immunochromatographic test. Any serological test is either it is an immunochromatographic test or ELISA, you can detect the toxin and cytotoxicity on cell lines. So second part, first is whether it is Corynebacterium diphtheria like bacillus is present or not. But even if it is present, you have to confirm it is, if you have to need to confirm it's Corynebacterium diphtheria, the presence of toxin must be demonstrated. And Elex gel precipitation test or tox gene by PCR. If you don't have PCR, you can do it by ELISA or immunochromatographic test. It already completed. Now this is an example of picture of Elex gel precipitation test. What is the, this part is the antitoxin soaked, a filter paper is placed in between the gel, the white part is antitoxin soaked paper, and then this inoculation, these yellow lines are inoculating lines of diphtheria toxin related culture. So this is a 1, 2, 3, 4, 5. Now how will you differentiate? Remember the antitoxin mediated filter. Now isolate 1 to 4 are toxigenic. 1 and 4, 5 there is no band appearing in the 5. So 5 is a non-toxigenic strain. 1 to 4 are toxigenic strain, and 1 or 2 are crossover bands. There is a crossover between 1 and 2. So toxin are not identical. So when you see 1 and 2, there is a crossover, crisscross cutting of the between 1 and 2. That means those two toxins are not identical. Toxin 2 and 3, toxin 2 and the partial fusion. Strains are partially related to each other but not identical, but isolates 3 and 4, they are fused to each other, so they are identical toxins. So this is Elex gel precipitation test. And what is the media used? Culture media used is horse serum agar plate. Horse serum agar plate used to do this Elex gel precipitation test. Now typing. What are the type of typing commonly used? Typing commonly used is biotyping. What is the biotyping? It is usually used in the past 4 biotypes: gravis, intermedius, mitis and Belfanti. These are the 4 biotypes that can be by biotyping. Gravis is 100% toxigenic and more virulent. What gravis produces? Gravis usually produces the hemorrhagic type of disease, and mitis produces the obstructive type of disease. So gravis, mitis and intermedius can produce both. So gravis, mitis and intermedius, what is the difference in the clinical feature? Gravis usually produce some hemorrhagic features and the mitis usually produce the obstructive features in the patient. Incidence decreasing. Widespread vaccination. Source of infection is carriers and cases carriers. Now what are the types of carrier? It may be temporary carrier or it may be chronic carrier. Temporary carrier means chronic when it persists more than a year. Then it is called a chronic carrier, but it is less than a year, it can call temporary carrier. And what is the most dangerous carrier is nasal carrier and throat carriers. Now transmission, how it transmission? Respiratory droplets and rarely by contact with infected skin. Common affected age is 1 to 5 years. Global situation due to widespread immunization, cases were drastically declined by 95% over the last 3 decades. Resurgence of diphtheria. In 2019, there is an outbreak in Tamil Nadu, Kerala and Karnataka. Majority of these cases were 5 to 10 years and low coverage of diphtheria vaccine area. Now what is the treatment? Treatment of diphtheria. What I have mentioned frequent before many a times in this class, that the treatment is anti-diphtheritic serum or ADS antitoxin. Antibiotic will not work alone. ADS or anti-diphtheric toxin must be used for the treatment. A test dose should be given to check for the hypersensitivity. It is either given IM or IV. So anti-diphtheritic serum ADS must be used. This is a type of passive immunization. This is the type of passive immunization. Early stage, less than 48 hours, what is the dose? 20,000 to 40,000 units. If it is a pharyngeal membrane present, 40,000 to 60,000 units of ADS. And in late stage, it has occurred more than 3 days. The dose is 80,000 to 1,20,000. Human antitoxin, this is still human antitoxin is not available. So, this is ADS must be used. What is the dose of ADS? Penicillin or erythromycin is the, now will you not give antibiotic? Yes, you can give antibiotic. What is the role of antibiotic? If you give before release of toxin, it can work alone. But after, even after the release of toxin, the antibiotic or antimicrobial will cool the bacteria, kill the bacteria and will decrease the further release of toxin. That is the role of antibiotic. So first is it prevents the release of toxin if it kills the bacteria before it releases, or after release it can kill the bacteria and prevent further release. So within 6 hours of infection because the toxin release. And treatment of carrier. What is the treatment of carrier? Carrier treatment is erythromycin. So erythromycin is the drug of choice for treating the carrier of diphtheria carrier. For close contacts, booster dose of diphtheria vaccine plus penicillin G single dose or erythromycin is recommended. Now protective titer 0.01 unit per ml of antitoxin. Vaccine not effective for cutaneous diphtheria. As I have already told, the cutaneous diphtheria is due to bacteremia, not due to toxemia. So, it will not be prevented by using the vaccine. DPT, diphtheria pertussis or diphtheria tetanus toxoid and acellular pertussis. Tetanus toxoid, adult dose of 2 low that initially there is a TD. TD means after 6 years you cannot give DPT. So what is that? That's why I was asking for the schedule. Usually it is given 6 weeks, at the age of 6 weeks, 10 weeks and 14, and then booster at 18 months and then booster at the age of 5 to 6 years. There you can use the DPT or the capital D where the LF unit is 25, but if you have to give in an adult, then LF unit you have to decrease to 2 LF unit. T is capital toxoid, D is small diphtheria. That is the difference between the capital D and small d. The LF unit is less, that is 2 LF units. Now pentavalent vaccine is also used. DPT, Haemophilus influenzae type B and hepatitis B. Can anybody tell why Haemophilus influenza B is as a quadrivalent or pentavalent bacteria vaccine, which is adjuvant? In DPT, pertussis part is the adjuvant in DPT vaccine. Now in Haemophilus influenza B, which type of vaccine is usually used? It is the capsular vaccine, that is mainly polysaccharide vaccine. So polysaccharide vaccine usually without adjuvant do not act below the age of 2 years. So here DPT, Haemophilus influenza B, is added with DPT, where the diphtheria and the tetanus DT both are acting as adjuvant. That is why we are now using the pentavalent vaccine, where Haemophilus type influenza B can be given earlier at the age of 6 weeks. Otherwise, it should be previously given after 2 years. Diphtheria vaccine, I have already told 6, 10 and 14 weeks. Another is 16 to 24 months and 5 years. Deep intramuscular, where you should give the deep intramuscular infection. Thiomersal is the preservative used. Always give DPT vaccine in the anterolateral part of the thigh. Never give in the gluteal region. DPT vaccination should not be given in the gluteal region. Why it is not given in the gluteal region? Presence of fat will inhibit the absorption of vaccine. So always give the either upper arm or anterolateral aspect of the thigh. Don't give the DPT vaccine in the gluteal region, because the presence of fat will decrease the absorption of DPT vaccine. The unit is 25 LF units for adult, but in children. But when you give it in an adult, it is 2 LF unit of vaccine is added. TD is recommended for adults above 18 years. Now, adverse reaction of DPT mild, wholesale kill vaccine of Bordetella pertussis is encephalotogenic. Absolute contraindication. What are the 2 absolute contraindications for DPT vaccine? That is, one is hypersensitivity to previous dose and progressive neurological disorder. That is the 2 absolute contraindication for DPT vaccine. Sick test, you just remember the name. It is a toxin antitoxin neutralization test, way used long back. Now it is not used. Just you remember the name, you heard the name. Diphtheroids, I have already mentioned, diphtheroids are corniform bacteria. They are non-diphtherial cornybacteria. Normal commensals in the throat and invasive disease in immunocompromised. How it is differentiated from Corynebacterium diphtheria? They stains more uniformly, palisade arrangement. That was key Chinese letter of cuneiform arrangement, but diphtheroids have giving a palisade arrangement rather than cuneiform pattern. Are rarely pathogenic. Sometimes the samples are discarded due to presence of diphtheroid as common cells. Remember this name, Corynebacterium minutissimum. This is called localized infection of the skin. Sometimes MCQ or the erythema can come. That is what is the causative agent for erythema? That is Corynebacterium minutissimum. It is called erythema. If you see it in a wood lamp, it will give an coral red color. Now this is over. So finally, if you take home message for the things is that first you have to get and for laboratory diagnosis, clinical suspicion is the most important part for the treatment of Corynebacterium diphtheria. Next is if you get 2 samples for throat swab to be sent, you can do an Albert stain or Gram stain. You get cuneiform of Chinese letter arrangement, a club-shaped bacilli, and the demonstration of the metachromatic granule. Then further, you must confirm by demonstration of toxin, whether it is a Corynebacterium diphtheria and toxigenic strain. So how you will demonstrate the toxin? One is LX gel precipitation test, or by toxin demonstration by PCR, tox gene demonstration by PCR, or by ELISA or immunochromatographic test. And the treatment is always start early. If you suspect diphtheria, anti-diphtheric serum is to be instituted.
So this is a zone where there is 2 different type of pH connects with that mix with each other, and that cervical zone vary in size according to the different stages or phases of menstruation cycle. So during the proliferative phase, it go above, and during the secretory phase, it goes below. and the most importantly, the HPV virus infection, most importantly, it affects initially the cervical zone, transitional zone. So from the transitional zone, mostly we have to collect the sample, transitional zone, TZ, transitional zone, we have to collect the sample. What are the method of sample collection? That is, how can we examine a smear prepared from the cervical material? The method could be of two types. One is conventional type, conventional pap smear. Why it is known as pap? Because the stain used is Papa Nicolau, and the short form of Papa Nicolau is pap. Stain is Papa Nicolau. Papa Nicolau stain is used to see the different type of the cell present in the sample taken from the transitional zone of a cervical region. That is why it is known as cervical pap smear. Usually there are two methods of examination. One is conventional type, one is liquid based cytology. Liquid based cytology. What is the difference between the conventional type and the liquid based cytology? আগের দিন কিছুটা শর্ট বলেছিলাম, এটা প্র্যাকটিক্যালেও বলা হয়েছে, বলবে কেউ? In conventional type, the sample directly taken and it is transformed into a smear over a glass slide. The sample is taken from the cervix and it is used directly to prepare a smear over a glass slide. But in case of liquid based cytology, the sample, from the sample, the different types of material, the cellular elements and other organism and might be anything that is directly projected within a preservative. That could be ethanol based preservative, could be methanol based preservative. So here the sample directly collected within a preservative. That could be methanol base, 100% methanol base or 95% ethanol base. তোমাদের দুটো নাম তোমাদের মনে রাখতে হবে। তো two important types of the liquid based cytology. One is, জানো কেউ? Sure prep and thin prep. 100% methanol is used in thin prep type of LBC, thin prep type of liquid based cytology. 100% methanol is used. But in case of sure path type of liquid based cytology, the fixative and the fixative use is 95% ethanol. 100% methanol is used in case of thin prep type of LBC, but in case of sure path type of LBC, 95% of ethyl alcohol is used. Okay, mone thakbe. Okay, how the sample is collected? কি কি আমরা ইউজ করি স্যাম্পল কালেকশনের জন্য? One is air spatula, wooden spatula. Another cytobrush. Another cotton tip applicator. Air spatula is used in conventional type, but cytobrush is used in liquid based cytology. Cotton tip applicator mainly used not in cervical cytology, but mostly it is used in vaginal smear swab collection. Cotton tip applicator is used in vaginal smear swab collection. Okay, and the most important stain used to see the cervical smear is Papanicolaou stain. Papanicolaou stain. Next question তোমাদের কি জিজ্ঞেস করবে cervical pap থেকে? What are the cells might present in a smear of cervical pap? What are the cells might present in a smear of cervical pap? কি কি থাকতে পারে, কি কি স্টেন, কি কি সেল থাকতে পারে বলো? দেখেছো তোমরা কি স্মিয়ার দেখেছো? দেখেছো? কোনো আইডিয়া আছে? কালকেই তোমাদের ক্লাস আছে সি ব্যাচের, আমি নেব, ঠিক আছে? আমি চেষ্টা করব দেখানোর। ওয়ান ইজ, যদিও তোমাদের এক্সামে নেই, তোমাদের জাস্ট দুটো ইনস্ট্রুমেন্ট আছে, একটা হচ্ছে আয়ার স্প্যাচুলা আছে, একটা সাইটোব্রাশ আছে, আর একটা হচ্ছে এফএনএসি একটা গান বলা হয়, ঠিক আছে, নিডল হোল্ডার বলা হয়, নিডল হোল্ডার আছে, বাট আমি স্মিয়ারটা দেখানোর চেষ্টা করব। হোয়াট আর দ্য সেলস মাইট বি প্রেজেন্ট? ওয়ান ইজ ectocervical cells. ectocervixে কি কি টাইপের সেল থাকে? ওয়ান ইজ superficial, one is paravasal and another is basal. Next, endocervical glandular element. Glandular element from endocervix. And third type of cell could be endometrial gland. Endometrial gland. Endometrial gland. Endometrial gland could be present. Most importantly কি থাকবে? Superficial cell. এটাই তোমাদের তিনটে দেখতে হয়। Most importantly superficial cell, paravasal or basal cell. These are the types of ectocervical cell. Second most common cell is endocervical glandular element or endocervical glands, and third is endometrial glandular element. Okay, there is a reporting system for cervical pap smear examination. There is a reporting system for cervical pap smear examination. কেউ বলতে পারবে কি বলে? Reporting system for cervical pap smear examination. This is your short note. তোমাদের upcoming short note. Reporting system for cervical pap smear examination is known as Bethesda system of reporting. Bethesda system of reporting cervical pap smear. Bethesda system of reporting of cervical pap smear. ফার্দার আমি বেথেসডা সিস্টেম নিয়ে এখন কিছু বলবো না। তোমাদের যখন গাইনিতে, মানে তোমাদের যখন ফিমেল জেনিটাল ট্র্যাক্ট আসবে, তখন আমাকে মনে করিয়ে দেবে বেথেসডা সিস্টেম অফ রিপোর্টিং নিয়ে, তখন বলবো। কারণ এখন যদি বলি তোমরা কোরিলেট করতে পারবে না। So this is in nutshell about gynecological cervical pap smear. Another point, আরেকটা, আর কি কি করা যায় cervical pap smear থেকে? Other than cellular identifying the cellular morphology, we can do some ancillary test, and most importantly from liquid based cytology LBC, the ancillary test can be done most easily. The most common ancillary test done is HPV co-testing. HPV co-testing. Why HPV is very important for in terms of cervical cytology? Because the most common cancer in cervix is, the site of cancer is ectocervix, and the most common type of cancer is squamous cell carcinoma, and the most common etiological factor, that is infection associated with the cervical cancer, is HPV, human papilloma virus. চারটে স্ট্রেন মনে রাখতে হবে, 6, 11, 18 14, 6, 11, 14 and 18. These strain are mostly carcinogenic strain, and these 4 strain most commonly associated with the cervical squamous cell carcinoma. এটুকু মনে থাকবে। কি কি বললাম মনে থাকবে? These are the points in nutshell about gynecological cytology. Next, তোমাদের যেটা জানতে হবে খুব কমনলি সেটা হচ্ছে FNAC, fine needle aspiration cytology. Cytology, fine needle aspiration cytology or FNAC. FNAC, why it is so important? The use of FNAC key. It is helpful to diagnose any kind of lesion, and it helps to categorize that lesion. So basically, it is helpful to categorize whether that lesion is infective, inflammatory, or neoplastic. If it is neoplastic, then it is benign or malignant. So it is helpful to categorize the lesion. Second, FNAC is used to identify some causative agent, like if it is a case of cervical lymph node swelling with history of fever, low grade fever, dry cough, or expectoration, or hemoptysis, etc., and on chest X-ray there is a consolidation in the upper lobe or in the paramedial area or parahilar area. So my or any clinician differential diagnosis could be tuberculosis. So in such cases, if there is a consolidation in lung, or suppose there is a lymph node enlargement that is known as lymphadenopathy, if I take a sample from that lesion and do a special stain known as Gill-Nielsen stain or Jaden stain, that Jaden stain will helpful to identify a special type of bacteria which is known as acid-fast bacteria, and the most common type of acid-fast bacteria is Mycobacterium tuberculosis, which causes the tuberculosis. So it is helpful to identify the causative agent. It is helpful to identify the causative agent. Third is FNAC sample. From that FNAC sample, that sample can be a tool for further investigation, specialized investigation. One specialized investigation is immunohistochemistry. What is immunohistochemistry? It is helpful to identify a specialized group of cell by their tumor marker. Different type, ধরো প্রত্যেকটা ইন্ডিভিজুয়ালকে আমরা তাদের নাম থেকে চিনি, তেমন ভাবেই প্রত্যেকটা সেলের কিছু কিছু অ্যান্টিজেন থাকে, যে অ্যান্টিজেনগুলো সেলের আউটার সারফেসে রিফ্লেক্ট হয়, মানে আউটার সারফেসে তারা বাইন্ড করে থাকে, and from that antigen the cell can be identified or group of cell can be identified. These are known as tumor marker, like cytokeratin. It could be a tumor marker of epithelial cell. একটা এক্সাম্পল দিলাম। এরকম ডিফারেন্ট টিউমার মার্কার তোমরা যখন সিস্টেমিকে পড়বে তখন সিস্টেমিক পোর্শনে দেখবে যে ডিফারেন্ট টাইপ অফ সেলের ডিফারেন্ট ধরনের টিউমার মার্কার থাকে। সো দিস টিউমার মার্কার কুড বি আইডেন্টিফাইড উইথ দ্য হেল্প অফ immunohistochemistry. This test will help to identify different type of cells or tumor marker. And from fine needle aspiration cytology, that is from the FNA slide, if we do this special examination on FNA slide, it is known as cytochemistry, cytoimmunochemistry. Why it is so important? From that cytoimmunohistochemistry, the sample which is taken from any mass, we can identify with which group of the cells are we examine at that time. Histo means আমরা এখানে histopathological tissue examination করছি, but cyto means একটা সেলের examination করছি. We can identify a particular cell in a sample with the help of this specialized examination, cytoimmunochemistry. So from the FNA slide, we can do that cytoimmunochemistry. And also some other ancillary tests we can do, like তোমরা পড়েছো flow cytometry or FISH, fluorescent in situ hybridization. These two ancillary tests could be easily done from FNA sample, fine needle aspiration cytology. And in older age group, I mean in previous era, we used to do some special type of stain to identify special group of cell. These are known as special stain. These special stain also identify a specific type of tissue. Like in case of fat, we usually do oil red O or Sudan black B. These two special stain are helpful to identify fatty tissue. Mucicarbine, another special stain. It is helpful to identify the adenocarcinoma. Gill-Nielsen staining help to identify the acid fast bacilli. So from that, for that particular doing the special staining, we have to do the sample collection, and from the FNAC, we can easily do that sample collection procedure. And the least, but it's not last but not the least, I think, is FNAC sample can be converted into histopathological block. FNAC sample can be, that is cell cytology, the cellular morphology. From the cell cytology, we can see the cellular morphology, but there are some limitations. So if that cellular sample can be converted into a histology block, we can easily identify the histological morphology of a tissue. So this FNAC sample can be useful to do morphological examination of a tissue, by a special procedure known as cell block technique. কি হচ্ছে, FNAC যখন আমরা করছি সেখানে নিডলের মধ্যে যে স্যাম্পলটুকু থাকছে সেই স্যাম্পলটাকেই আমরা হিস্টো ব্লকে কনভার্ট করছি বাই দ্য প্রসিডিওর নোন অ্যাজ সেল ব্লক টেকনিক। বুঝতে পারছো তোমাদের there is a major diagnostic role of FNAC in most of the pathological conditions. Not only we can see the morphology of a particular cell or identify a tissue or identify a causative organism for a particular disease, but also this sample can be converted into a histopathological block so that we can easily diagnose the different type of morphological character of a particular tissue by histopathological examination. And this bridging technique is known as cell block technique. This is a bridge between the histology and cytology. তাহলে বুঝতে পারলে দিস আর দ্য ইউটিলিটিস অফ ফাইন নিডল অ্যাসপিরেশন সাইটোলজি। ওকে, কি কি রিকোয়ারমেন্ট হয় তোমরা দেখেছো এফএনএসি প্রসিডিউর কোথাও? আমাদের ডিপার্টমেন্টে গিয়েছো এফএনএসি? আজকেই 4খান এফএনএসি হয়েছে, গিয়েছো আমাদের ডিপার্টমেন্টে? সেন্ট্রাল ল্যাবে আমাদের এখানে এফএনএসি হয়, প্রতিদিনই হয় একটা দুটো, আজকে 4খানা হয়েছে। দেখেছো কেউ? ক্লাস হয়েছে তো তোমাদের? হোল্ডারটা দেখেছো? সিরিঞ্জ হোল্ডারটা, ওটা কি করে, কেন ইউজ করে? হ্যাঁ বলো, একজন বলো। পড়েছো তো? কালকেই একটা ব্যাচে পড়ানো হয়েছে না? ব্যাচে দেখানো হয়নি? মেশিনটা দেখানো হয়েছে। সিরিঞ্জ কি করে ওটাতে আটকানো হয়, কি করে পুশ করে দেখানো হয়েছে ব্যাচে। কালকে কাজ ছিল ব্যাচের, টুমোরো ব্যাচ সি থাকবে। ব্যাচ বি দেখেছে? ডু ইউ হ্যাভ এনি কাইন্ড অফ আইডিয়া অ্যাবাউট দিস ইনস্ট্রুমেন্টস রিলেটেড টু দ্য এফএনএসি? আছে? কি কি লাগে সেখানে? একটা সিরিঞ্জ লাগে, একটা নিডল হোল্ডার লাগে। নিডল হোল্ডার বলে না সিরিঞ্জ হোল্ডার বলে? দিস ইজ নোন অ্যাজ এফএনএসি গান or FNAC syringe holder, not plunger. Plunger is something used in prostate FNAC. Prostate থেকে যখন FNAC করা হয় তখন প্লাঞ্জার ব্যবহার করা হয়। বাট তার আগে বলে রাখি, FNAC can be done of two types. This is basically of two types. One is direct and one is guided. ডাইরেক্ট আমরা কোথায় কোথায় করি? সাপোজ কোনো লিশন আছে যেটা প্যালপেট করা যাচ্ছে বডি সারফেসে, লাইক ইন থাইরয়েড লোব সোয়েলিং or any soft tissue swelling like in lipoma or any cystic swelling, epidermal inclusion cyst. So if there is any swelling over the body surface and we can palpate it, from that swelling we can aspirate the sample by the direct method. কি কি দরকার হয় সেক্ষেত্রে? ওয়ান ইজ সিরিঞ্জ হোল্ডার লাগে, সেকেন্ড ইজ ওয়ান সিরিঞ্জ লাগে, সিরিঞ্জ মাইট বি 10 cc and একটা নিডল লাগে, আইডিয়ালি 24 to 25 gauge needle লাগে, but if there is any bony tissue then needle could be 20 gauge, and if it is done for a child the needle size could be 27 gauge. This is very important. Ideally we do the FNAC by 24 to 25 gauge needle, but in case of bony tissue we use 20 gauge needle, and in case of child we use 27 gauge needle. এছাড়া কি লাগে? একটা গ্লাস স্লাইড লাগে। Okay, over there we spread the sample. Okay, but in some cases, some instances, majority of instances basically, the lesion is deep seated. Suppose if there is any lung carcinoma or pancreatic carcinoma or liver carcinoma, kidney carcinoma or any sarcoma, deep seated sarcoma, how can you aspirate that sample from a deep seated lesion? পারবে? Directly পারবে না। So under the guidance of radiology we have to aspirate that sample. That guidance could be under USG, under CT, under fluoroscopy, under colonoscopy or endobronchial ultrasound. এতগুলো রেডিওলজিক্যাল টেকনিক আছে। With the help of this kind of radiological technique we usually assume at what extent that deep seated lesion is present. সারফেস থেকে একটা লিভারে কোনো এসওয়েল থাকলে সেটা কতটা দূরে আছে, এসওয়েলটা কতটা বড়, তার ভিতরে ভাস্কুলারিটিটা কতটা, সেটা স্প্রেড কত দূর পর্যন্ত হয়েছে। Under the assistantship of this kind of radiological system, we can aspirate the sample from a particular deep seated lesion. Suppose USG guided FNAC, USG guided FNAC done in case of thyroid or breast or liver or pancreas, etc. CT guided FNAC, CT guided FNAC usually done from lung or pelvic organ related pathology. Fluoroscopy under fluoroscopy guided FNAC done in case of lung lesion. Colonoscopy, of course, colon, or endoscopy guided, of course, কি আমাদের endoscopy, I mean upper GI endoscopy. If it is lower GI, then the sample is taken under the guidance of colonoscopy. And endobronchial USG is useful for diagnosis of pancreatic lesion. Okay. So these are the types of FNAC we can do with a patient. What are the common fixative use in fine needle aspiration cytology? বলো কি কি ফিক্সেটিভ ইউজ হয়? মোস্ট কমন ফিক্সেটিভ কি একটু আগেই বলেছি, most common fixative used in all kind of cytology is 95% ethanol. তোমরা কপলিন জার দেখেছো? That 95% ethanol fixative is put in the coupling jar, and that slides on which we have to do the pap smear. We usually fix that sample in 95% ethanol. তো এখানে তাহলে কিছু কথা বলে রাখি ফিক্সেটিভ নিয়ে। Why the fixative is important? Fixative মানে কি? These are the agents which are helpful to fixative. Fixative কি? Fixatives are the agent Fixative are the agent which are helpful to prevent any kind of autolysis of or degeneration of the cells to be examined. Any substance which prevent the degeneration or damage or autolysis of a sample is known as fixative. বুঝলে? যা যা কেমিক্যাল এজেন্ট আছে যা কোন রকমের সেলের ড্যামেজকে প্রিভেন্ট করে তাকে ফিক্সেটিভ বলে। মোস্ট কমন ফিক্সেটিভ ইজ 95% ethanol. Fixatives are basically two types. One is dry fixation, one is wet fixation. Fixatives are mostly dry fixative and wet fixative. যখন আমরা দেখবে এফএনএসিতেই রোমানস্কি স্টেন করি, রোমানস্কি স্টেন নাম শুনেছো? তোমরা তো ফিজিওলজিতে পড়েছো লিশম্যান জিমসা স্টেন। It is included in the group of Romanowski stain. So when we do the Romanowski stain in a slide, we usually dry the smear in fresh air. It is known as dry fixation. But when we do other than Romanowski stain, most commonly the Pathology stain or some special stain, we do wet fixation. ওয়েট ফিক্সেশন কিসে? ওয়েট মানে কি? These fixatives are basically liquid chemicals. Most commonly 95% ethanol. আর কোন ফিক্সেটিভ জানো? 100% মিথানল। আর কোন হ্যামারেজিক ফ্লুইড, সাপোজ তোমরা বডিতে কোনো হিমোপেরিকার্ডিয়াম হয়েছে, সেখানে তার কোনো পজিটিভ এজেন্ট জানতে হবে, তার মধ্যে আরবিসি প্রচুর আছে। সেই হ্যামারেজিক ফ্লুইডকে যদি আমরা ফিক্স করতে চাই, তাহলে hemorrhagic fluid, for hemorrhagic fluid we use Carney's fixative. Carney's fixative. These names are very important for your MCQ purpose. Carney's fixative. Okay. Then for the electron microscopic examination, 2.5% glutaraldehyde acts as a fixative. 2.5% glutaraldehyde acts as a fixative in electron microscopy. And for the IHC, usually the 95% ethanol acts as a fixative. Okay. So, প্রথমে স্মিয়ার বানানো হলো। These are fixed with either wet fixation method or dry fixation method, and then we have to do some staining. Okay. So, স্টেনিং কি কি হতে পারে? ওয়ান, একটা তো বললামই, রোমানোসিস স্টেন। রোমানোসিস স্টেনের একটা এক্সাম্পল দাও। লিশম্যান জিমসা। আদার দ্যান দ্যাট, লিশম্যান জিমসা কুড বি মে গ্রুনওয়াল জিমসা স্টেন ইন জিজি স্টেন, জিমসা স্টেন as such. These are all Romanus stain. Papanicola stain, there are two component. One is Papanicola stain can you use করে? Because it is very good stain to identify any pathology related to the nucleus, যেখানে নিউক্লিয়ার ইনভলভমেন্ট হচ্ছে। দুটো কম্পোনেন্ট থাকে। ওয়ান ইজ হ্যারিস হিমাটক্সিলিন, another is ইওসিন অ্যাজিওর। এর মধ্যে হ্যারিস হিমাটক্সিলিন স্টেন is used to stain the nuclear component, and ইওসিন অ্যাজিওর helpful to stain the cytoplasmic component. So there are two components of Papanicola stain, Harris hematoxylin and ইওসিন অ্যাজিওর. Okay. So with that staining, we can easily identify the cellular morphology. But এখানে কিছু ড্রব্যাক থাকে FNAC, যার জন্য আমরা হিস্টোপ্যাথোলজি করি। Most important drawback is FNAC, the name only suggesting it is only the study of cell, but we cannot study the entire tissue. So for the entire tissue, we have to do the histopathological examination, and it is very difficult to very difficult to identify the cellular character by cytoimmunochemistry. But it is much easier to do the immunohistochemistry in a histopathology section. So this is an important drawback. And third important drawback is FNAC in the background, the blood material, some mucus material, etc., obscuring material or intervening material can be present within the field, which acts as an obstacle to identify different pathology of a cytology. So it is very, very important, necessary to identify the whole tissue, like in mucinous carcinoma, যেখানে স্টোমার মধ্যেই প্রচুর মিউসিনাস মেটেরিয়াল আছে। তো তো মিউসিনাস কার্সিনোমাতে সাপোজ একটা নিডল মানে একটা ওভারিতে ধরো মিউসিনাস কার্সিনোমা আছে, সেখানে মিউসিন পকেটের মধ্যে একটা নিডল ঢোকানো হলো, সে কি করবে? শুধুমাত্র মিউসিন মেটেরিয়ালটাকে অ্যাসপিরেট করে নেবে, সেলটাকে অ্যাসপিরেট করতে পারবে না। যদি না পারে তাহলে কি আমরা সেলুলার মরফোলজি বুঝতে পারবো? Then how can I differentiate? Is it a benign or is it a malignant case? So we have to do the whole histology examination, তাই না? So these are the drawbacks of FNAC, and that is why we usually do the cell block technique. So this is in nutshell, I think. এইটুকু তোমরা মাথায় রেখো তোমাদের জন্য। আমার মনে হয় না এর থেকে বেশি কিছু তোমাদের জানা এখনই দরকার আছে। ফার্দার তোমাদের যখন সিস্টেমিক এক্সামিনেশন হবে, মানে সিস্টেমিক পোর্শন তোমরা পড়বে, you gradually come to know different types of investigation or ancillary method of investigation to diagnose a pathology of a particular tissue. তখন তোমরা কোর নিডল বায়োপসি, ট্রু কাট এক্সেট্রা এই সমস্ত টার্মগুলো তখন জানতে পারবে। ওকে, it's a very, I mean, I must say this is a largest topic of your practical. I mean, it's a very tough and largest topic, and not, to me this is not so important for you for your practical purpose. But of course যে কোনো সময় শর্ট কোশ্চেন অন্তত আসতে পারে, অ্যাটলিস্ট আমি যে টপিকগুলো পড়ালাম তার উপরে।